We will go ahead and get started. We're going to, this is actually the second training in our second year of providing training to OCFS. So I'm excited about that. And I'm excited to have each and every one of you here today. Today, we're going to be discussing something that is very serious, but something that is also pretty hard to navigate. And so we have a discussion on mental health and suicide prevention for youth. This training may be triggering or upsetting for some of you. So I wanted to take time to acknowledge that and to tell you to please be mindful of your own mental health and participate in the ways that you feel best support you. So many of our youth we serve are navigating new milestones in preparation for adult roles involving education, employment, relationships, and homelessness. These transitions can lead to and amplify various mental health challenges, and those can also be associated with an increased risk for suicide. Currently, we know that suicide is the second leading cause of death among youth ages 15 to 24. So during this session, we will explore best practices and interventions to assess, to engage, and to service youth currently experiencing mental health concerns or suicide ideations. My name is Angela Huff. I use she, her pronouns, and I'm Associate Director here at Point Source Youth. I'll be moderating our discussion today. Our first hour is going to be Q&A, and then we'll leave about 30 minutes on the back end for you all to ask questions. So as we're going through, if you guys go ahead and type it into the chat, if you have any questions, any comments that you want us to be able to look at, go ahead and feel free to put those in the chat. So we're going to get started. I'm going to ask each speaker to introduce themselves, and we will start with Jamie.
Everyone, my name is Jamie Hunn. I go by she, her pronouns. I'm a licensed clinical social worker. My background is working in community mental health with children, adolescents, and families, primarily in the group home setting, youth that are in state custody or reside in psychiatric hospitals. And I'm currently working in pediatric healthcare, doing emotional wellness programming for healthcare workers. And I'm excited to be here. Thank you.
Thanks, Jamie. And we will pass it on to Jessica.
Hi, everyone. Good afternoon. My name is Jessica Cornelius. I go by she, her pronouns. I am a LMSW, and I'm currently working with Montefiore in their school health-based program as a social worker. I also do fee-for-service therapy on the side, specifically with adolescents and young adults, and long history, child welfare, also in regards to case management as well as homeless youth as well. So thank you for having me. I appreciate it.
Thank you, Jessica. Omerix.
Hi, I'm Omerix Rosa. I'm a case manager with Jericho Project's Rapid Rehousing Program. I work with young adults and young adult families who are homeless, and we assist them financially with housing. I also have a long history working with the Center for Court Innovation, the Harlem Community Justice Center, where I worked with for a number of years with young adults in their reentry program. And thank you for having me.
Thank you. And Amanda.
Hello, everyone. My name is Amanda Leppert Gomez. I'm a youth with lived experience of homelessness and mental health problems, or the struggle with mental health. I'm also a youth action board member as a part of Atlanta's youth homeless demonstration program. And I'm working at Our House, which is an organization that serves families experiencing homelessness, as a program services coordinator. And I also have a background in applied medical anthropology. When I go back to finish my master's degree, I'll be looking at the intersection of access to mental health care, trauma, and health disparities.
Thank you all so much for being here. And we're going to hop right into it. And so we know that mental health is something, especially nowadays, that I think that people are paying a lot more attention to for good reason. And so I wanted to just take the time to put some context around it. And so if I'll start with Amanda, if you can give some context on the disparities faced by youth experiencing homelessness with mental health, that would be
Absolutely.
great.
I think that the number one disparity for youths experiencing homelessness with mental health is the disparity in access to quality mental health care, and more specifically, trauma-informed and trauma-specific mental health care. My own experience of homelessness was mainly caused by a long history of domestic sexual violence impacting my mental health. I have complex PTSD and depression. And every time I connected with and met with someone in the system, I made it very clear that I have a history of trauma impacting my capacity to function on a daily basis. This was the major reason I became homeless, and I needed to connect with trauma-focused mental health care. And the only referral that I was given in my first 3 months was, as part of this program, the counselor said she could only meet with me for 30 minutes temporarily, and we would only need to meet 2 times per month. So basically an hour a month to attempt to fix years of trauma. And in the meetings, she said we didn't really have time to unpack and deal with the trauma due to the structure of how things worked and the limitations of the program. Basically, my needs were greater than what can be provided for, and this is the experience of many youth experiencing homelessness. In total, it took me 3.5 months to finally get connected with a great trauma-focused counselor that is meeting my needs, even though I continuously said that this was a priority for me that needed to be taken care of since day one, because it's my major driving factor, driving me to homelessness. And honestly, the only reason I was able to get access then was because I was lucky enough to have access to a widely accepted private insurance plan through my parents. This is the same thing with my sister, who is experiencing homelessness from playing DV. It's been over 4 months. She's still not connected with a trauma-informed counselor. And for my husband, who's an immigrant and doesn't have access to insurance at all right now, it's been over 6 months, and he's just finally getting connected to care for his depression. And so the explanation for these disparities in access is multifold. First of all, in the focus of case managers and the professors formed by the programs providing services to youth experiencing homelessness often don't integrate mental health as a priority, and they really push you to focus on your income and your job without helping you figure out how to find a sustainable balance that also allows you to prioritize and treat your mental health. A holistic approach that tackles the root causes of individual situation of homelessness is often not allowed for in the context of programs limitations and deadlines of when you need to have things figured out by or end up back on the street. And then the second thing is access to quality mental health care right now is really based on income level and insurance. The difficulty finding a good trauma-specific counselor, even when you have access to private insurance, is it's terrible. It's takes a long time. It's frustrating, defeating, and it's even worse if you're dependent on Medicaid or community-based clinics. A lot of great trauma-specific counselors don't even accept insurance. It's really a class-based system that leaves those with the most intersectional needs with the biggest barriers to access to care.
Thanks, Amanda. You brought up some really good points. And one of them, as you were talking, that stood out to me is really when providers have other priorities or make other priorities for you above what you've set as your own priority. And so I think that was something that I wanted just to highlight as well, to make sure that if we are saying that we're going to be youth-centered, that we have to consider the priorities of the youth. And so thank you for bringing that point out, and so many others as well. Jamie, would you like to add on to that as well?
Yeah, I mean, that was really well said. And I'm sure I'm not alone in saying that it was really painful to hear, that's our reality and that was your experience, Amanda. I'm sure a lot of us are feeling very protective of you right now and frustrated that happened to you. As a community mental health provider, I will say, and this isn't just with mental health, unfortunately, we practice on poor people. And so what happens is we get folks that are fresh out of school that are going through training, their associate license, which is great. But your associate license, you feel really incompetent as a therapist because you're new to the field, and they give you some of the most complex cases. And you're paid very poorly. and the need of your clients and like the self-sacrificing that you go through, it becomes really frustrating. And so by the time a lot of people get fully licensed, they leave community mental health. So by the time, to Amanda's point, that they are quality trauma-informed practitioners, they've left and they've gone to work in private practice for a multitude of reasons. And that is really, really hard. We're not putting the resources necessary to take care of our people in need, as well as the people that are taking care of our people in need. And I also just like to go back, because I worked a lot with youth in group home settings, and there's a large distrust of medical professionals or just adults in general. Adults have not been safe and they've not been protective and they haven't shown up for us. So whenever they're telling us that we need to take meds, we don't trust them. And so I do think not having adults that we trust, that folks have attachment to, modeling appropriate mental health care and the need for medication and being transparent really hurts their ability to connect with their mental wellness and the steps they need to take. A lot of my youth, would say, I don't need this because I'm not quote unquote crazy, because there's a lot of stigma out there. So I think not having caregiving systems that are appropriately modeling the importance of our emotional wellness is also a big part of the disparity.
Thank you for that. Did anyone else want to jump in there?
Definitely, I would like to second that frustration that JD said in terms of as a case manager, when I refer clients to, for mental health counseling, and they're ready, especially our youth, they're ready right now. And then having them to wait 3 months for an appointment for just to be able to be seen is very frustrating, because they're ready now. And just at the moment, you don't want to wait 3 months into the line. And when they're like, okay, the issue's gone, I don't want to do it no more. So they change their minds a lot in terms of that. So you want to meet them where they're at that time. So it's really frustrating as a service provider.
Yeah, that's a good point as well. And in my experience, I've had youth who have been resistant. And so when they are willing and open and saying, yes, I want this service, I want this help, and for the resources not to be available or readily available, it is re-traumatizing in a way, and so it does create a frustrating system. And so thank you for bringing that up. But I also you touched on something that I wanted to bring out as well is, getting youth to a point where they want to be open and are receptive to receiving services. So I wanted to hear kind of what engagement techniques do you all use when you're talking about and having conversations around mental health and suicide and things of that nature. And Omerix, if you can start us off, that'd be great.
Well, one of the main things is being transparent, being honest with them on what your limitations are to confidentiality. That's the first thing. We are mandated reporters, and we first have to let them know, okay, we're mandated reporters, imminent harm or danger, some things that might have to report, but being totally honest with them, that's going to build the trust. And I think they could tell a mile away very quickly whether or not we're being genuine with them, Also acknowledging that speaking about mental health and suicide is awkward, is weird for a lot of them. And sometimes it's even hard for us to be able to speak to them about it because it's triggering to us as providers. And one of the ways that we deal with it is through supervision, through training, through normalizing it and using that as a model for them as well. And normalizing it just as we normalize any medical issues as well. Like if they had diabetes, they would go get help. They would go to the doctor, get insulin. The same way we try to normalize the situation, actively listening to them, asking questions, letting them vent, A lot of times the youth, what they crave is someone to listen to them, to be heard, to be seen. Also be direct with your question, not sugarcoating it, asking them, are you planning to hurting yourself or killing yourself? Do you have a plan? When, where, why? So asking those questions, not being afraid of asking those questions to them. Being empathetic. Like if they tell you something, like believe it and be there. And also, like I said, also know your limitations. You are human. So, this conversation might be triggered for you as well, okay? And using the best practices, models like motivational interviewing, harm reduction, strength-based, positive youth development, using those to be able to deal with this.
Thanks. Did any of the other speakers have any techniques that you all want to share or any thoughts around it as well?
I guess I'd like to share, also just kind of maybe piggybacking off of what Omar have shared, but I think tone and presentation is a really huge part of building rapport and even having someone come to you and express something that is so vulnerable. Mm-hmm. I think patience, right? Because some people don't have the words to outright say, I'm thinking this, I plan to do this. And so being patient with them, right? 30 minutes is not enough to do a efficient safety assessment, from the get-go, when someone comes into my office and either they're brought down by another professional or coming in I don't want to say straightforward, like from the beginning, but it's really much of a care and concern, like what's going on? I'm hearing that you're not feeling so great today, or I'm hearing that you've been sad, right? And so sort of trying to meet them at their emotion before we get into this whole logical piece to make a smooth transition. Because if someone, I've learned, like if you come right out with, so you want to hurt yourself, you want to kill yourself, why, what, it just kind of really causes a person to potentially shut down, and then you lose them, right? So I think definitely patience, honesty, tone, and educating. Like I find myself sometimes, reflecting back to them, like I'm not inclined to send someone to the hospital. Just because you tell me that you're having these thoughts doesn't mean that you're going to go to the hospital. But in order for me to make in like accurate assessment, I need to know more about this. And usually that can sort of open up the door for them to say more. Definitely normalizing it in a way as well, that like, you're not the only one to go through this. And if you are, it's not wrong, it's not bad, right? Like behind suicide, people want help. I personally believe, and that's the way that I approach anyone that comes into my office that I'm working with, is that they want help, right? And sometimes they just feel so helpless or hopeless that they can't see that. And so I feel like my goal is to sort of empower them to see that, like, even if you're talking to me and let's say you do have to go to the hospital, like that's help, and that's positive, right? And what comes after that. So all of those things.
I love that. And I see you, Jamie, came off mute, but I love that meet them at their emotion. That's something I haven't heard before. And I'm like, oh, let me write that down real quick because that is important. Jamie, go ahead. I see you want to add something.
It really is. I mean, Jessica articulated it so well. And just to build off what she's saying, let's start it at intake. Like, let's start at the beginning and let's ask these questions. Like, has there been a time where you felt really, really low? And then and let's build on it. Like, and we're starting our conversations with youth about being mandated reporters. And so we can ask about, has there been a time where you felt really low? And to everybody's point, we're normalizing that sometimes we want to quit. Like sometimes life is so hard. And unfortunately for so many of us, there's been moments where we just didn't want to do it anymore. And let's normalize that. You know, what isn't seen can't be healed. And for all of us, we can acknowledge that there's been moments where it feels easier just to stop. So if we can say that and acknowledge that it's normal, and we're going to do it with them in a whenever they're not escalated, then we can ask them, like, what are your warning signs? Like, if I walked into the room, how would I know that you're not doing really well? Because it's so important to me that I show up for you in those moments. So while they're calm, collected, we're doing intake or we're building rapport, even if it's a week or so in, let's ask those questions now so that we're not being reactive and we can be proactive.
Good points. Very good points. And so I know that this time being 18 to 24, being a youth in general, is just a stressful time. There's a lot of decisions that have to be made, a lot of transitions that are taking place. Then if you add on what's happening in the world, there's a lot of trauma that can take place. And then if you add on to the fact that a youth may be struggling with homelessness as well, you know, there's a lot of trauma in that. And so my question is, how does trauma connect to mental health and suicide? And then also, what are the ways that we can use trauma-informed care, which I know I've heard a couple of times already, to address the mental health for our youth? And I will ask Jessica, if you want to lead us off.
Sure. So, I mean, if we just look at trauma, right, and what it means, it's any abrupt experience, I think, that sort of stays with you and changes the way that, let's say, like your brain reacts. And so there's big T trauma, little t trauma, and I think like this is information that people should know and don't often know. And so I think taking that and knowing that everybody is different, and so like what they consider to be trauma and how they experience their trauma, and you know how it shows up is going to be different. So there's no one way to approach trauma. I'm not sure if everyone is, you know, aware or keen to the adverse childhood experiences study that was done, and you know, just sharing that there are certain things, if anyone experiences before the age of 18 related to like, I think like family dysfunction, abuse, or emotional neglect, like this puts you at a higher risk for things like health concerns, things like mental health needs, as well as substance use and all these other things. And so even if you have one, you are at a higher risk to likely experience mental health concern, whether it be depression, anxiety, right? And so trauma sort of recalibrates the way that your body sensations and your nervous system works. And so I think that we have to, as individuals working with others, always come from this space of being mindful, again, and pacing ourselves when we're coming in contact with someone, because there's a lot of parts of their identity that can't be seen. And so we need to ask questions. We need to sort of work from a place of empowerment and sort of strength based as well, and trying to make a person feel as safe as possible when they are working with you, because you don't want to make the mistake of re-traumatizing them again. But then also like being, you know, accountable and sort of recognizing like, hey, if I do make a mistake, if I do say something, like let me know. You know, I always share that you are the expert on your life, you live the experience. I'm just here to sort of bring in some alternate perspectives and help you develop skills. And I can't do that if you don't give me the information. So I just think pacing is really important. A lot of trauma brings forth sense of helplessness, hopeless, you know, sort of like this fatigue. And these are things that show up with regards to mental health symptoms like depression, anxiety, PTSD. right? And so it's all connected. I consider it to be like a domino effect. And so I think you just have to work from that space.
Thank you for sharing that. And Amanda, it looks like you want to jump in there. I'm feeling your energy.
Yes, I am. I really like what you said there about the domino effect and the interrelation between traumas and mental health and stuff like that. It's usually in a larger context for a lot of people, especially if have had experiences of abuse or domestic violence. And so in order to try and like paint this picture a little bit clearer for you guys, I wanted to share just like a snapshot of my family's struggle with intergenerational trauma. In my immediate household, every child out of the 4 of us had experienced either childhood sexual abuse and or domestic violence and or other experiences of sexual violence by the time we turned 18, with some of us experiencing some sort of domestic violence or sexual violence continuing into young adulthood. My parents also struggled with their own impacts, for one of them of childhood sexual abuse, the other one a different type of sexual violence. Parents with their own experiences, struggles with substance abuse or problems with their own histories of trauma, domestic violence in young adulthood, and that leading into things like alcoholism, so because due to like inadequate supports and resources for their own healing. And so upon finding out about the traumas we experienced, they tried their absolute best to support us in our own healing with the limited resources they had. But ultimately, they could not and did not provide for the full emotional needs of their children and processing and healing in a healthy way. Honestly, they did some more harm because they also never had those examples and experiences themselves. And as a person who's embedded in the survivor community, this is a very, very, very common experience. In my family, I would argue until very recently, none of us had received the full support and resources we needed to heal for many years. Honestly, for most of us, probably not still. But in my family, 1 child has died of suicide. 2 more children struggle with suicidal ideations. Almost all of us struggle with depression. Several of us struggle with PTSD or complex PTSD. And so far, 2 of us have experienced homelessness before 24. So as I hope my story can help you see, often the connections between trauma, mental health, and suicide are interrelated and compounding, because there's a clustering of these traumas and mental health conditions that are interacting in like multifaceted ways within an environment of complex interrelational traumas and dysfunction itself. So being trauma informed and providing trauma informed care means recognizing that with these complex layers of traumas that individuals and youth have experienced and the various ways and coping methods we've used to relate to these experiences and ultimately just survive, the individual journeys that each of us will go on for our healing and our mental health will take years and often a full lifetime, as we keep on relating to this in different types of ways and processing it in different types of ways. Personally, I've been on this healing journey for about 8 years now, with more intensively focusing on my mental health and prioritizing my healing over the last 3. And so implementing trauma-informed care to meet these needs means providing youth with providers who are capable of meeting us where we're at on that journey. Who've done their work and are skilled in destigmatizing the struggle with experiences of trauma itself, with the struggle with mental health, so that we can feel safe enough to fully, truly engage with them instead of keeping on our masks. Because most times I'm going to show up, I have a mask, I'm this person, not the same person that I am with all of these different traumas and mental health problems, right? And so, we need people who can also understand that, like, understanding something conceptually or logically versus fully feeling that, healing that, and enacting a change in our relationship to these life stories also takes a long time. It's a very iterative process. So we really need people who have taken the time to deeply understand the intricacies of the types of traumas we've experienced, who are comfortable about talking about what's taboo in society and make environments that show that. who are always responding with validation, with compassion. They're providing support at each step, because we often can't find that elsewhere, not necessarily at the fault of our individual parents, our families, our communities, but rather because this is a much larger syndemic context that's happening throughout society. The amount of people who have trauma and abuse in particular are much higher than what we care to show and we're comfortable talking about in society. So youth really need people who are really comfortable talking about that and like destigmatizing that and letting them start taking those layers of protection down, their walls down.
Thanks so much, Amanda, for sharing that and being so transparent and being so open and honest and brave. I do appreciate all the points and for sharing your personal story with each and every one of us. And as I'm listening to you and I've listened to some of the other comments, I feel like there's almost like a underlying theme that's kind of coming out, is like sometimes providers are not necessarily trained in the way that they need to be in order to handle these conversations. And so I wanted to take a minute and just ask for a minute, what are some tools, what are some resources that providers need in order to be better equipped to handle mental health crises and even suicidal ideations? And I don't know, whoever wants to jump in there to start it off, that's fine with me.
Can I just share? I'm sorry, Omar. You want to go?
No, go ahead. Go ahead.
Can I just share? I mean, coming out, being in grad school, I think this starts really early in career building and coming into, like, I don't think enough emphasis and practice was put around navigating a crisis or a suicide assessment. And I think that this should really begin very early on in the practice. I also have just sort of taken it upon my own self, right, to read more about it. So workbooks, any type of updated statistics that come out like that. That's something that I personally have incorporated into my own practice and skill building. I think that continued training, sometimes we have these trainings, but we don't actually it's like, here's the material, go practice it. And I alone. And I think that there needs to be a lot more, this is the training and we're sort of doing some, we do like mock interviews and things of that nature, and having someone who can consistently, whether it's a team, a couple supervisors, whatever it is, like having someone that will debrief with you around these experiences so that you yourself as a provider don't burn out, to sort of empower you and build your confidence is not the word that I'm looking for, but just like ability to sit in a room and hold space for someone who's going through something that's really scary. I remember the first time I did a suicide assessment, I was very scared, and every time I've done it, it's always looked different. And some people I've had to send to the hospital and some people I haven't. But I also remember the times where I was supported after and how I was directed to navigate to take care of myself, but also show up again for whoever else might need me. So I just think that starting it early in school, and then, you have to do the personal work on your own because society is always changing, right? And trauma looks different. So that's my personal take on it.
For me, I think, let me piggyback on what Jessica said. The importance is on training, not just from the beginning of, going to school when you first go to school for training like that, but also through supervision. Using supervision as part of that training where theory versus real life. This was going to happen, for our textbooks. says to do when a crisis happens versus this was what you will do when a crisis actually happens. So that's part of it, you know, having that discussion with peers and your supervisor as well, to be able to go through it so you won't burn out and you'll be able to be better prepared in the event something else happens, you know, another incident happened, and going through it back, okay, how did you handle it? Okay, what should have been the best course of action? Having that discussion. So trainings and ongoing supervision, but also one other thing that's really important as a tool is collaboration with other service providers. For example, as a case manager, being to collaborate with mental health, community mental health professionals, to be able to say, hey, I need to make an appointment for this client. I don't want to send them to the emergency room right now because but they do need counseling. Are you able to give me an appointment within like a week or so, not 3 months from now? So collaborating, and also collaborating and having trainings with other service providers. I think those are some of the resources that we definitely need as service providers to use as tools.
Thanks. I think that's a really, really good point. Even as you all were talking, and I'm like, oh, I can hear some people in the audience. Like, I can feel you guys saying, you know, I don't provide mental health services. You know, my focus is housing, or my focus is something else. And so really having that partnership with someone who does, and being able to quickly access it is what I heard you say. Is, hey, I get an appointment within a week? And really just having the relationship and being able to do that, so that you're not making these cold referrals where people are waiting months and months to be assessed and to get services. So having that collaboration is key for those that do not provide the service themselves. So thank you all so much. And something else that I heard you say was like through the supervision and really just understanding the best practices. And so my next question is going to follow up on that, which is, what are some best practices when working with youth who are resistant to medication or their mental health diagnosis? I know that I've had some youth that I've worked with in the past that are like, yeah, I was prescribed certain medications, but I don't want to take it. For whatever reason that may be. So what are some techniques that you all have used to educate youth? And I saw, Jamie, your eyes kind of went up a little bit there.
Yeah, I mean, I acknowledge that I am a mental health provider, and, reflecting on the previous statement or the previous question and conversation, I do want society to move into a place where we all feel more comfortable being uncomfortable. I don't want folks to feel like they have to be a mental health professional to talk about mental illness, mental health, suicide. I want folks to feel more comfortable knowing that we're going to have moments that we're uncomfortable. Like, we're not going to get through this life without suffering, and it's okay. We're not meant to be comfortable all the time. So with that being said, you all can talk about medications, and you don't necessarily have to be a mental health professional. You can say, I don't know, when you don't know. You can say, let's make an appointment and go together and ask these questions, or safely utilize Dr. Google. But what I do typically whenever I'm talking to youth about medication and their caregiving system, or even the adults that I work with, is I try to talk about it in a scientific way that's understandable for most. So I talk about like our neurotransmitters who are sending messages throughout our body, and like neurotransmitters tell us when to feel happy, when to feel sad, and they're moving. So I say they are like mailmen. And so some of these mailmen don't get to our brain. They don't bring happiness to our brain the same way that other people's mailmen bring happiness to their brain. And that could be genetics, that could be trauma, that could be stressors. It can just be a thing. But we're experienced, if we're getting to medication, like if we're having that conversation, then this is chronic and more chronic, and the coping skills and the things that we've been trying to do and teach, like they're not necessarily working. Like they're outside of this window where they're able to receive and apply the information that we're trying to do in like therapeutic work. So I say, like, our mailmen aren't working. And sometimes we need to go talk to somebody who works in medication because they help get the mailmen where they need to be so that we feel safe and we can start to do the work. Because if we're outside of our window and I'm sitting in therapy and I'm trying to work with my counselor and they're telling me I should try deep breathing and I should journal and I should have the conversations with the people that are upsetting me, but I literally just can't. I just can't. I won't, I can't. I don't feel motivated. I'm no longer responding. We need to get some help that can look like medication. And there's other examples, you know, like bipolar disorder and other mental health diagnoses that would we'd go down a medication issue. But largely, I just try to meet them where they're at and talk in a way that's like, it's our mailman. Like, we're not getting messages to our brain to be happy like other people are, and we need help with that. So let's go ask. I'm not saying you need them because I'm not qualified to say you need them. So maybe let's just go ask and see where we're at and see if we can get some more tools.
So one of the other things that I want to mention here is that mental health journeys and medication is a long process, an ambiguous process, a process where you don't know what the destination can and will be. And if it's related to trauma, their experience, or other things, like medication alone won't be the determinant factor for improvement for many people. It's high quality therapy, which we know that isn't available to many. And so I feel like that should be the first step, is making sure they're having access to really good, high quality therapy. Even being said, I don't want to stigmatize medication. I'm on medication myself. Like, I have been on medication for 3 years, and it's like, mental health journeys and medication in particular take a lot longer time to maybe help than a lot of the other different types of medical diagnosis. And they may not even address the main complaints of the youth itself, as they have to go through this a lot of side effects. For me, I went and tried to finally start thinking about medication due to my lack of energy. 3 years later, I can sleep. I'm having different things with my PTSD addressed, and I'm trying to, I think maybe my medication is working a little bit with my energy level, but it's still not addressed. And now my psychiatrist is saying, like, she doesn't have very much hope of it being addressed with medication anymore. Like, we have to explore other options. And so, like, often, like, it's taken for granted the power difference in between a clinician and a youth who is receiving services, but we need to, like, see youth as the primary stakeholder in their own mental health journey, and they need to be treated as such because they have valid concerns. They know themselves best, and if they're going to go on this long journey, I mean, if you're a person who's not good at taking medication every day, you can, like, end up sick for the next 3 days if you forget your medication one time. You can be, like, vomiting and have diarrhea. It's a terrible process. If you accidentally forget to take your medicine a little bit early, you can end up in the hospital for 24 hours because it was an accident and you were, I don't know. It's like, it's a big thing. It's a big journey. And, like, youth have to be on board with that process in their healing journey. Often the first reaction in a lot of clinical spaces and many other institutions to a lack of trust or a lack of agreement is this idea that the individual has a lack of education, which is leading to their lack of trust in the institution. And there's not that deeper analysis of if the institution has a long history deserving of the individual's trust by all of the intersectional identities they show up in. Because often it isn't the case. There's a lot of psychiatrists who are not trauma informed. I've showed up into a psychiatrist's office to be treated for PTSD. He asked me about how my anxiety felt. I talked to him about an instance that I had a flashback. He said something like, well, you don't know that's related to your past, right? And in my mind, I'm thinking, well, yeah, obviously I know it's related to the past because I can tell you the exact same moment and the exact same trigger where it took me back to. But, like, a lot of times that's, like, not been analyzed? How many truly trauma-informed and trauma-specific clinicians are there that the youth is having access to? How have they been received by the different youth that have been there? How have partnerships with those closest to the problem been consulted to change the culture of the institution and the quality of services provided? Because those are all things that can happen. I mean, not even just thinking about like, if you're trauma informed, are you also culturally specific? Are you like showing up in these different ways? Are you providing services in a way that people can hear and understand and relate to, that address their main needs? So like, what I want this room to see is to kind of step away from that neoliberal model of patients who are adequately or inadequately acting in the face of their conditions and their diagnoses, which makes their outcomes justified or whatever, and start moving to an equity model and a youth-centered model that truly analyzes the structural problems that leads to the trends that we see, and start working with those communities to enact change that is needed in our institutions. Yeah.
Thank you for saying that. Go ahead, Jessica, so you come off mute.
Thank you, Amanda, for sharing. One of the things that I like to sort of carry on when you shared it, it was something I was pending saying. I do acknowledge like cultural sensitivity is necessary. And so I, work in this model of transparency as needed, but I bring my identities into the space. And so I'll say something, like, if a person does not want to take medication, like they have every right to make that decision that they do not want to take medication. And I acknowledge that. But also the question is not why, because that's blaming, but tell me a little bit about what is going into this decision of not taking medication. And then I'll bring into the fact of like, I am a professional, I'm on this opposite side, but as a Black woman, right, in my culture, we don't take medicine. You don't need medicine. You pray, you do these certain things, right? And so you have to really understand what is impacting a person's decision not to sort of work with that and then provide education. Sometimes people have these fears, like I'm gonna start medication and then this is like, I'll never be able to get off of it. And that's not true, right? So we wanna be able to sort of educate people appropriately. And that, again, medication is not the end all be all. Honestly, a lot of the times to really get an accurate picture of a person, whether it's their trauma, whatever it is that they're coming and bringing into the room with them, you need to see them multiple times. You need to collaborate with the providers, right? Symptoms can change from one moment to the next. And you also have to be honest that it might take a little while to even get the appropriate cocktail of medication for a person to take. And people may not want to go through that. Some antidepressants take up to 6 weeks to really take its full effect, and so do people feel like they want to wait, right? So I think it's a lot of education and conversation before you even well, we're going to try medication. It's what have you thought? What do you know about medication? What have you thought about it? Do you know anybody who's on medication? So it's many things. And just like Amanda said, if you do not take your medication consistently, there are going to be ample side effects. So if you have somebody who is homeless, if you have someone who can't make it to appointments consistently, that is going to impact their ability to appropriately take their medication, which could further harm them. And so that's not what we're trying to do here. So I think, again, mindfulness and just pacing yourself when you're working with someone and trying to help them understand what the best course of action would be. So that's what I've written.
To piggyback on what Jessica said, also empowering them to ask questions and voicing their concerns, because a lot of times they're like, well, they hold off on asking those questions because they believe they can't ask those questions because of that power dynamic. But I think as providers, being more youth-centered, being open and encouraging them to voice their concerns and why don't they, like, or what do they feel, educating them as well. Definitely.
I did want to ask for the providers that are on here, and I heard you say, Jamie, you don't have to necessarily be a professional. So I do want to hear kind of what are some signs of suicide risk that service providers can look out for and be aware of, because sometimes they may be the in-between. They may be the first person that, and the only person in some situations that are seeing certain signs. And so what signs are out there that they should do, and what, once they see them and notice the signs, what should they do? If that makes sense.
Yeah, of course. So signs to look out for are like expressing feelings of hopelessness, like things just aren't going to get better and I don't see the light. Like if we sense that they are not able to see the light and they're just experiencing hopelessness, that's a sign. Like we just need to check in. Talking about death, just basically talking about death. Like if they bring it up and make comments, like it can be easy to avoid responding to those comments and in our head convincing ourselves that it's just a joke, but we need to stop and pause and check in on those. Changes in hygiene are also something to look out for. If folks stop taking care of themselves as much, or just in the same way, we know that folks experiencing homelessness, that can be a completely different circumstance to just access. So we want to acknowledge that. And if we notice a shift in how they're carrying themselves, it might be an opportunity to just check in. If folks start giving away their belongings that we know are near and dear to them, and saying like, I really want you to have this, we might ask like, you're making me kind of nervous. Like, I know that this is really important to me or important to you. How are you? What's going on with you? I want you to have this thing. I don't want to take this thing. You take care of it or something like that. But those are just small things. If they're keyed up or on edge, just kind of withdrawing from folks, muscle tension, and you just notice that they're not coming around as much, or they're not as engaged. These are more opportunities to check in on folks. And we just ask the questions, how are you doing? We haven't checked in a minute. How are you doing? Or we can reflect. I've noticed that you haven't been coming around and talking to us as much. Is everything okay? And like pulling folks off to a quiet room where they feel more comfortable opening up and talking. Oftentimes people feel comfortable if they have something to fidget with. Love a fidget. If they have something in their hands that they can mess with while they talk, or in a car, people are really good at talking in the car because we don't have to look at each other. Those are opportunities to facilitate conversations and check in.
Jessica, you look like you want to add something in there.
I was just thinking about, it's not necessarily a sign, but one of my supervisors that I never forget shared with me, sometimes it's easy for people to sort of give this passive expression of like, oh, it would be fine. It would be better if I wasn't here. And it can be very easy to sort of like overlook that comment because we might know working with them that they have a lot going on. But she taught me to ask like, oh, so, are you thinking about killing yourself? Or, have you ever thought about suicide? They might say no, they might say yes. And to ask, well, how would you kill yourself if you were to do it? Or like were to hurt yourself? Because that is more, some people might say, oh, I might just take, some pills, or they might actually tell you. But so that question in particular, because in learning how to navigate this experience, that was really helpful for me. And once I started to implement it, even if it was someone that had like passive suicidal ideation, I could say passive suicidal ideation with plan, no intent. Versus just passive suicidal ideation, because there's a difference of someone who just thinking it and doesn't have a plan, and no intent versus someone that's thinking it, has a plan, no intent, so that was really helpful to me. So it's not necessarily a sign, but just a question to sort of like put out there.
Good stuff. All right, so I wanted to jump, if we can, to this question. How can we equip youth who are living on their own independently to maintain their mental health and to prevent suicide ideations? And Amanda, you look ready to go, so I'm gonna go ahead and ask you to start.
Yeah, the biggest thing I'm gonna say here is to create true relationships with the youth, so that the working dynamic between you guys really understands them, their needs, and co-develops like whatever those actions plans are in your guys' encounter holistically, like starting at intake and maintaining throughout the whole relationship. Oftentimes there's like a set of required questions. It's very clinical. We're just asking a question because we're told to ask a question. But no, we really use those tools to like start building that relationship and get to know each other and show that you're listening to what they're saying and what they're needing. And like, you think that that's important too. Often encounters when you're working with youth are siloed to whatever your professional objective is, without understanding that there's like intersectional aspect of the youth's life that impact that objective, if that makes sense. So like, I really want you guys to start seeing youth as key stakeholders and really like colleagues almost, and working in your working relationship together. Create spaces where it's safe to show they're struggling without being judged for it, or told that you're like at fault or causing your problems in your own way. Oftentimes there's this like thought for trying to keep youth accountable. We're kind of trying to be really tough on them, but then that like makes it, sometimes there are things that are going on and there's struggles that you're really struggling with, this thing's happening, but it just keeps happening. You still have to have help with that struggle. And if you're like a person who's like being really tough on them, you're not going to be a safe person to start talking about these struggles and getting help that they need with those struggles. So having active listening, validation, empathy, nurturing support, the ability to have crisis intervention conversations, which might not be a mental health crisis. Maybe their crisis is, I need help getting to a domestic violence resource center, or I need, I can't come up with things on my own, but like really like sitting through, okay, there's all of these things that are going on. I'm very overwhelmed. I don't know where to start going with that. And so like you listen to what they're saying, and then you start like, okay, this is how we can work through this together. First, we're going to do this, then we're going to do this. Okay, check in again later. Okay, how did that go? Okay, now we can start doing this, stuff like that. So like kind of like take that overwhelm and have somewhere to like take it and like get support with it to work through it. Because that's often like the biggest thing with mental health and suicide, is that not being able to work through that overwhelm, not being able to figure things out, and like having a true support person that can work through that, like can make a bigger difference. So like when you're doing referrals, please do warm handoffs and follow-up, not just those called referrals, waiting for the agency to call or the individual youth to call and assume it's going to work out. And then if you've already created that safe space, and you're asking like, oh, hey, how are you? And they're saying, oh, I'm fine, I'm okay, whatever. Like sometimes just like really pushing again, I'm like, no, but really, how are you? What have you been struggling with lately? What's your day-to-day been like recently? And like giving the space that it's okay to come up as a full person and like get that support with. But the biggest thing I want you guys to try and do, and keep trying even though it's hard, is to like get them connected with really quality resources that sufficiently meet their needs, and keep fighting for those, especially because we know it's so hard to get connected. And so when you're overwhelmed, it's like so much harder, but having someone who will keep fighting and pushing for you can make a big difference.
Thanks for that, Amanda. And go ahead, Amorex.
Okay, one of the main things is providing advocacy for mental health counseling and assistance, but providing it, advocating for it, not just in locally, but also empowering the youth also to be able to advocate for it as well. Also, advocate for services that are needed, also provide the resources to obtain those life skills needed to be able to maintain independent housing, providing financial management, different little life skills that are needed that will lessen the stressors of everyday life of living on their own as well. Also providing ownership of their needs and wants, listening to that, what they want, I'm not saying you have to live, like, for example, not saying you have to live here because of it, listening to what they want and, explain to them what the realities are, because that could also be a stressor in terms of mental health as well. Things like that.
Thank you for that. Did anybody want to jump in on this?
I think I just want to add also asking, when someone becomes like when they start to live on their own, there's a lot that comes with that. And so helping them to learn how to also problem solve. And so one of the things I've tried to be mindful of is not immediately giving the answer, but sort of asking them, so what do you think you should do? And then what makes you think that? Or sort of, so what would be the consequence if you do that? And sort of working through it with them before giving well, not even giving, but asking so can I share my thoughts with you? Because they might not want your thoughts, right? They just might want to come to you and be like, I'm gonna do this, I'm doing this, and want you to support them. And it's okay. And then in terms of what Amanda said, sometimes they can say that they're fine. And me is how I work in a high school. So I'm like, are you for real fine or are you fake fine? Which one do I know that I'm working with, right? Because sometimes they just saying I'm fine is easier than going into this long-winded spiel of what's going on. And sometimes you kind of have to, you'll find the balance of letting a person be fine and pushing a little bit to get more. So that's just my addition to that.
And I think from you guys' comments, my big takeaway is slow down. Slow down. When you're greeting someone, it's how are you doing? It's not just something that you're saying. Sometimes, you go throughout your day and you're like, hey, how you doing? And you don't even listen for the answer. You don't listen for the response. But when you ask the question, actually wait and listen, not only to the words that people are expressing, but the emotions that they're demonstrating, right? And their body language and all of that goes into it. And just taking a minute to slow down and to breathe. And then I think I heard maybe Amanda say earlier during the intake process, even, slow down. We know that you have to answer questions. We all have these sheets and all these documents that have to be completed. But there's a way that you can have a conversation that builds rapport versus you just being so clinical, is I think how you said it. There's a way for you to get the information that's needed for you to do what you need to do, but there's also a way to let the youth be able to speak in their own voice in the way that they feel comfortable in communicating. So a lot of great points that I've heard so far from everyone on this call. So I personally am learning a lot, and hopefully I know everyone else is as well, because I'm reading through the comments and people are really appreciating the information that is being shared. I did want to ask a very targeted question. So this question is specifically for you, Amanda. And my question is, what makes you feel affirmed, trusted, because I've heard that phrase a lot today too, and supported from a young adult's perspective?
For me, one of the biggest factors usually is how much of a trauma-informed environment it is, because that's my life story. And there's spaces where it's safe to show up identifying with that and struggling with that. And there's safe spaces where it's really not safe. I really appreciate when there's been a lot of work that's been done to understand those driving factors that led me to be in that situation I'm in, and like truly proactively address them, which might take a long process to try and figure out, might take a little bit extra work. But like, if these are the things that led me into the situation, and we're not just gonna go like, well, this is like, boom, 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 this is how you do this. Like, is it actually dealing with those like problems, or am I gonna like still deal with them? But like, one of the biggest things is being seen and treated as like a holistic individual with my own best interests at heart. Like that working relationship and how it developed from the start. Did it truly listen to my needs, empathize with them, create a plan, again, that proactive addresses and centers these goals and needs? What types of problem solving have we done together? Have I been treated as I'm trustworthy, or have I been in an environment like where it just feels like they're waiting for me to mess up and write me off? Like, being a young adult, you're going to struggle with things, and that's to be expected. You're going to make mistakes. You're going to be in patterns that you know that you're doing this and you know it's not good for you, but you're going to keep doing it because that's like what you did to survive for so long. And it's like an iterative process to change that, to get out of that, to struggle with that. Has there been space for me to struggle? Has there been space to understand that logically understanding a concept and then practice of implementing it and understanding that concept on deeper levels as you practice again and again? Like, oh, you said this thing and now I'm understanding it even more. And oh, I get that now, but oh my God, now I get it even a deeper level, you know? Like, how has this space been set up to join me on that journey? And honestly, the best way to start setting up practices like that is making sure you're having really youth-centered spaces and youth-led spaces. You can invite youth to the table when you're doing programming, when you're doing program evaluation. We have a lot of good ideas. Will really help you start to learn. If we're in a space to do so, we can be honest and say like, hey, you know, when I say these things and you like react this way, you like feel awkward, it makes me shut down and makes me know it's not a safe space. So like, we can have that practice of like doing so, but make sure if you're going to do that, that you're actually compensating us for our time, because we're going through a lot too. But yeah, just.
That's perfect. Thanks, Amanda. Thank you so much. Safe spaces. And I think that the way that you talked about safe spaces is, you know, I think sometimes people define it in different ways. And so just when you're thinking about safe space, you know, give me the space to grow. Give me the space in the room to be able to change my mind if I want to, you know, or to be able to do different things. And so I really appreciated hearing that. So thank you. I did want to get a couple of questions that we have from the audience, and we're going to go back a little bit. So one of the questions was centered around when we were talking about youth that may be resistant to medication. And it says, what about if a youth has had a bad history with drugs? They were given drugs against their will and things like that, which has led them to become resistant to medications. How do you handle that? And I'm going to ask Jamie if you can talk about that a little.
I mean, to your point earlier, I think that that's a big indicator that we need to pause. We need to stop. We need to pause. Because if we think about like the 4 R's of trauma-informed care, one of them is resisting re-traumatization. And this sounds like a trauma trigger. So yeah, I would say I would take a pause, and we need to do some internal work. And there's going to be a heavier emphasis, to Amanda's point earlier, like medications alone is not solving the generational trauma, the cycles of trauma responses that we've created in our life. So we're going to need more in the therapeutic arena, and we need to, if we are open, to everybody's point earlier, to taking medications, and this is a journey that we feel like we need to get on, but we're nervous because of our past history with drugs. I think that in therapy, we have to reevaluate and construct our relationship with medication and differentiate what that was and what this is, and what is different. This is not the same, and it feels like the same right now. So we need to have almost like an exposure therapy where we're like actively working towards re-entering this relationship with what is like drugs, even if it is, you know, like a street drug situation versus like a psychotropic medication. But definitely my answer is working with a mental health provider to work on that relationship with medications.
That's good advice. And this question is for you, Amanda. Can you give some perspective on how you maintain or to rebuild relationships with youth that are trusting of you with information that may have led to them being hospitalized, or something that came out of providers being mandated reporters? So how do you rebuild that trust? How do you, reestablish it and build that rapport back up?
You know, that's a hard question, because one of the biggest things, if you've experienced trauma, is like getting your power taken away from you, and really like being empowered to have your own journey and your own choices is really good, like important. But I think one of the things that we can start talking about is like giving space to listen to that frustration that person felt, and hear it and sit with it for a second and validate it. And say, you know, I'm really sorry that you had to go through that. I know it really sucked for you. That's something that oftentimes we don't get from adults, but we really, really need. I also am thinking about like giving space to process of what that journey or what that experience meant for them, and kind of see, is there different takeaways from that event? So like, for example, in my family, I got told a lot of different things about what being involved with child and family services would mean for my family, for my brother, for my sisters. Did that really happen? How can I feel about that? What did I learn from that? And like making sure that we're like being clear again about when these things get told and these other consequences happened, was it actually the end of the world to the extent we thought it was going to be? Or did something else come through it? But I really think that giving that time to hear and listen from the individual's point of view, and to like maybe ask, please ask them what it would take to build that relationship and that trust with. They might not have an answer right away. It might be in a next meeting a month later, whatever, but like that would be a really good thing too, to try and start building that trust up again.
Thanks. And I think I heard someone earlier say, you know, that you're upfront at the intake, that you're a mandated reporter. So just maybe reminding and having that information out front so people are not caught off guard, I think is always helpful. But I was also curious, Jessica, if you can speak a little bit about it, because we've heard you say that you've had some folks that you've had to send to the hospital, but how do you build that rapport on the back end of it?
Yeah, it's not always easy to do that. So I think like even just in the process, I like acknowledge that this is gonna be maybe not the easiest experience. And I try to sort of set them up as much as possible of like what to expect, but also am very honest, like I haven't been here or there, you know, and so I don't know what it's really gonna be like. But I wanna try to keep you safe. And after being consistent in my follow-up with them, like especially if they're returning to me and I ask them about it. And I mean, the other day I had a person that I had to send to the hospital, and when I called her mom was like, I can't go, I have to go to work. And I like had to sit with her and just sort of like, that was really terrible, you know? And just, she's still hospitalized. And so the idea is, I said that I would see her 2 times a week. So making sure that I see this person 2 times a week, asking about their experience, validating their experience, you know, asking, are you upset because I made this, because, you know, we had to make this choice? And if they are, like, that's fine. Don't personalize the feeling, like they're allowed to be upset, you know? And like, that's really it. Just being as honest as possible and allowing a person to have their own feelings and kind of come around to whatever that may mean afterwards. So.
Well, thank you so much. I appreciate each and every one of you. This was a great discussion. We are just at 4 o'clock, so right at the dot, finishing up. But I did want to take a minute to remind everybody that this session has been recorded, and so we will have a video that is posted, as well as a toolkit that will go along with it. I wanted to make sure to thank all of our panelists, our experts, for sharing their personal stories and just really giving us so much insight onto this very important topic. That's really all that we have for today. Also wanted to remind everyone to register if you have not already for the national conference, which is happening next month. But until next time, I appreciate each and every one of you for joining us. Thank you again to our panelists. Amanda, thank you, thank you, thank you. We appreciate hearing your voice in this very important discussion. So hopefully everybody has a wonderful rest of your day.